Hello, I'm Nathalie Farpour-Lambert from Geneva, Switzerland. I'm the president of the European Association for the Study of Obesity, and it's a great pleasure to present for you my topic, which is school closure, what is effective. So what do we know now about school closure? The most important reason leading government to close school was the evidence that the early introduction of this restrictive measure had to be effective in reducing influenza incidence rate and related clinical, social, and economic problems during both seasonal and pandemic influenza outbreaks. But it's not all certain about that the same advantages can be expected in the case of COVID-19 pandemic. School closure may also have a negative effect and lead to greater medical, economic, and social problems. Modeling studies indicate that school closure can be significantly effective for infection control only when the outbreaks are due to viruses with low transmissibility and attack rate are higher in children than adults. This applies to influenza viruses and influenza infection, but did not seem to be valid for coronaviruses, including SARS-CoV-2. The literature review shows that children under 10 years old account for only 1% of COVID-19 cases. Also, a certain number of them can experience an asymptomatic infection. The total number of children with COVID-19 seems lower than expected. To date, no official data are available, to my knowledge, on the effectiveness of school closure during the COVID-19 epidemic. However, we have a few data from different countries and a small systematic review. In Taiwan, the risk of transmission of infection among children in a classroom was very low, with an R0 less than 1, clearly highlighting that school closure could be only marginally effective. In a 2020 systematic review, Wiener and al. Showed that there are no data on the relative contribution of school closure to SARS-CoV-2 transmission control. We have some data from mainland China, Hong Kong, and Singapore, which suggests that school closure did not contribute to the control of the epidemic. And recent modeling studies of COVID-19 from the United Kingdom, using data from the Wuhan province in China outbreak, predicted that school closure alone would prevent only 2 to 4% of deaths, much less than other social distancing intervention. So what can be the potential negative consequences of school closure? The problem is that to take care of the youngest children when daycares and schools are closed, because in the majority of countries both are closed, parents must remain at home with inevitable economic consequences because they cannot work. When the parents are healthcare workers, this can have relevant medical effects. In the US, it has been calculated that the absence from work of 15% of healthcare workers may be associated with a significant increase in COVID-19 mortality. And this problem has been highlighted in many countries in the world. If parents must work and grandparents must become the primary caretaker of children, the risk significantly increases that these persons who are at the greatest risk of serious illness may become infected. So then we get negative effects instead of getting positive effects. There is also a risk of excessive weight gain due to reduced opportunities for active play and exercise, as well as limited access to quality food. During the lockdown, interestingly, food companies have reported that consumers stock up on shelf-stable foods and purchase ultra-processed, calories-dense comfort food, such as cookies, sugar-sweetened beverages, and ice cream. So we might expect that children staying at home and being eventually stressed by the the COVID-19 epidemic may eat more and gain more weight. We may have also some negative consequences on learning. We know that the COVID-19 pandemic increased risk of deepening social, economic, and health inequities, and particularly in limited income countries or in limited income regions. The distance learning through digital technologies to replace traditional school can be difficult to implement, even in some industrialized countries. In Italy, for example, a survey carried out by the National Institute of Statistics in 2015 showed that in the poorest area of the country, 41% of the household did not have a tablet or a personal computer, and that among families with at least one child, only 14% could guarantee distance learning. In Geneva, and I will talk about the Swiss experience later in this presentation, we have also observed difficulties of establishing distance learning with families with low socioeconomic status. So we had to set up a phone call and also to ask the parents to come to the schools to get the school exercises and back to home and then back to school. So it was very complicated. School closure and financial hardship can therefore contribute to a disproportionately higher risk of obesity among children and in poverty, in addition to affecting education. We know also that during the school closure, the daily routine may be quite disrupted with more irregularity in pattern of play, eating, schoolwork, and sleep. And the lack of sleep is, as the evidence shows now, that the lack of sleep in children is associated with increased weight gain due to increased food intake during the day. So how and when school can be reopened? That some countries are still in lockdown, some are in the beginning of the phase of reopening. So this is a very difficult question. We know that during the influenza outbreak, reopening has been associated with the risk of epidemic resurgence. The best solution for the COVID-19 pandemic is not known. It has been suggested that children who test positive on serologic tests that identify IgG against SARS-CoV-2 could be admitted to school. But it is supposed that positivity could allow the identification of children who have already been infected, and that they can be considered protected and can attend school without posing risk to, per se, to other children or to teachers, because teachers are very afraid, very careful and afraid to get COVID-19 in schools. But the sensitivity of the presently available antibody test is suboptimal, and most children have asymptomatic infection. And as the immune response to SARS-CoV-2 infection has been found to be greater, the more serious the disease is, it seems likely that most children will have a low antibody titer that is inadequate for obtaining positivity on tests with relatively low sensitivity. So even when IgG levels are measured, it's not possible to state whether children are protected or how long the protection may last. In Geneva, we have now some data on serologic tests showing that about 10% of the pediatric population has been infected by the COVID-19. But today it is too early to know if these children will be protected in 1 month, 2 months, or 6 months, or maybe in 1 year. So taken together, these factors seem to indicate that most children with IgG positivity cannot be identified, and even if identified, cannot be considered protected for the long term. So we have, I'm from Geneva, Switzerland, and we are in the phase where we have reopened schools since a few weeks now. And so I would like to share my Swiss experience. the government decided to do only a partial closure of schools and daycare center from the 16th of March to the 11th of May. So when parents were healthcare workers or were involved in essential services like police, but also in supermarket to provide food to the population, the children could attend school or daycare centers. Interestingly, we had only about 300 children in daycare centers and school during that period. We realized that many parents, when one parent had to work, the other one was usually taking care of the kids. In some situations, they had to ask the grandparents to take care of the children, but we tried to avoid that in encouraging people to bring their kids to childcare center or to school. So we did differently compared to other countries like France or Belgium, which totally closed childcare center and schools. We did information campaign for teachers and parents, prepared videos before the opening to explain that the risk of transmission, virus transmission, was very low in children, and to date we had no data about inter-children transmission in Switzerland. We also, so the protection measure included physical distancing, and the distance was set at 2 meters in adolescent over 16 years of age, or the distance had to be maintained between children and adults. But there were no measures if the children were under 16 years of age, so they could just live normally in schools. They could play, be together, and also the tables in the schools were at the usual distance. We didn't change anything. On the contrary, we increased hand washing. So they had hand washing session 5 to 6 times per day at arrival, before the break, after the break, before to go home. So we did intensive hand washing, and the results was that we had some irritation, skin irritation, sometimes in some children because they were washing hands too many times per day. We developed educational support for teachers and children, flyers, posters, video, and we set up a training program for teaching for hand washing. We also included cleaning surface measure 1 or 2 times per day, including tables in schools, but also doors and toilets. The children could arrive at school between 8 and 9 to make sure that not all children and parents were coming to school at the same time. School breaks were also between 10 and 11 by class groups. And what we did, the national schedule was reopening of primary school and secondary school from 4 to 15 years old, the 11th of May in half classes and half day. And then on the 27th of April, we reopened everything for children from 4 to 15, so full classes, full day. On the 8th of June, we did for adolescents 15 to 19 years old, we did half classes and half day, and they had to maintain the physical distance of 2 meters between them and between adolescents and teachers. Vulnerable children, so children with severe cardiovascular disease, respiratory disease, immunosuppression, had to stay at home, as well as teachers, and symptomatic children and teachers were immediately isolated and tested. I would like to show you the data from Geneva from beginning of March, so the beginning of the epidemic in Switzerland to now. And we can observe here is a total number of people tested in Geneva for COVID-19, and in blue, the number of positive cases. And you can see from the beginning of March to the the end of April, an increase in the total number of people tested, so having symptoms, and in blue, the increase of the number of people positive for COVID. So we had the peak around the 30th of April, and then we can observe a slow decrease of people tested, and then stabilization, because we really encourage people with any symptoms of upper or lower respiratory tract infection or fever to be assessed. But what's interesting is to see the number of positive case diminish quite quickly, in a few weeks, in 4 or 5 weeks, to reach a very, very low point here. So we had, in total, we did 40,000 tests since early March 2020. We had 5,230 positive tests with a mean of 12.5%. But now at the moment, we have less than 1% of positivity. You can see here the distribution of COVID-19 cases by age and gender in Geneva. And you can see that the majority of cases were between 20 and 70 years old, mainly the active population, slightly more men than women. And in children, you can see a very, very small number of cases. So we had in 0 to 9 years old children only 0.7, represent only 0.7% of cases. And it's even lower than in the international data. And between 10 and 19, we had 2.2% of positive cases. It was representing 2.2% of the total number of COVID-19 cases. We recorded no deaths, hopefully, and a week ago, which was interesting. So we opened the school on the 11th of May. We are almost at the end of June, and a week ago, suddenly we had an increase of the number of tests in children under 10 years old due to light upper respiratory tract infection. We did 663 tests, and only one remained positive, so 0.15%. In 10 to 19 years old, we did 388 tests in a week, and we had only one positive test, so it represented 0.25%. When the child, what's interesting, when the child was positive, one adult was infected before the child, so we managed to we did the evaluated the contact, the close contact, and then we came back weeks ago, and we always found usually one parent who was positive, sometimes 8 weeks or 10 weeks ago. We had no evidence of inter-children transmission and no school cluster. You can see here the incidence of COVID-19 per 100,000 people by age and week in Geneva. And at the peak, you can see here that the incidence was much higher for people over 70 years old. In children here, it's very low. It was maybe a maximum of 40 cases per 100,000 people at the peak of the epidemics. And you can see not much difference, in fact, during the period compared to adults. What do we know now about childhood obesity and COVID-19? A recent Swiss case report study from Geneva described the clinical characteristic of 3 adolescents, 10 to 12 years old, who presented in septic shock, defined as a severe infection leading to cardiovascular dysfunction. All had confirmed infection with SARS-CoV-2. 2 of them had signs of peritonitis and multiple organ dysfunction syndrome, and met the definition of pediatric multisystem inflammatory syndrome temporarily associated with COVID-19. Interestingly, all 3 cases had a BMI greater than the 97th percentile for age, so they were in the category of obesity, which raised the question of whether obesity is a risk factor for severe COVID-19 related complication in children, as reported for adults. Low-grade inflammation and altered immune function, as well as endothelial cell dysfunction, have been demonstrated treated in children with obesity, which might explain the susceptibility to the pediatric multisystem inflammatory syndrome temporarily associated with COVID-19. However, this report do not prove a causal relationship between obesity and COVID-19 development and progression in children, and more studies are urgently needed in the pediatric population. In conclusion, the potential advantages of school closure, if any, have to be balanced against the secondary adverse effects. Instead of school closure, total school closure, alternative strategies to contain transmission could be implemented, such as reducing class size, physical distancing, hygiene promotion, screening with temperature measurement, as some countries do, adoption of face masks in adolescents like Belgium or France, closing classroom with infected students. In Switzerland, we promoted hand washing and surface cleaning, reduced class size, we applied physical distancing between adults and children. To date, preliminary results are encouraging. I would like to finish with a few recommendations for government related to childhood obesity and COVID-19. They should prepare for potential increases in rates of childhood and adolescent obesity and initiate response planning related to access to care for physical and mental health, reducing food insecurity, increasing opportunity for physical activity, and addressing inequality for those most vulnerable. They should also increase access to evidence-based intervention for obesity prevention and treatment during and following quarantine. In Geneva, what we did, we maintained the teleconsultation during the lockdown, so children and families with obesity were not left alone, and they had the most recent guidelines and protection measures, as well as guidelines to manage physical activity and nutrition during this phase. We recommend also to promote access to nutritious food and ensure the continuity of school food programs, and consider farmers markets if possible, which often provide specialty and ethnic produce and prepared food valued by immigrant communities as part of essential food services, but also create social distancing plan. We, in Geneva, we really developed farmers markets, and it was really interesting to see how the population was certainly interested to buy food from Geneva, from the region. We believe that it's important to make school physical education as a priority with home lesson plan and fun exercises classes broadcast via television, videos, and secure internet streaming and recording. It's what we did in Geneva. Unfortunately, it was not generalized, so not all children had from the same age had the same program, but we had individual initiative from physical education teachers. We also think that it's important to maintain child safeguarding activity during the lockdown. We know that during the lockdown, many families were facing difficulties with living with their children, especially families with low socioeconomic status, and we have really to plan and fund an increase in work capacity to protect the children. So I have listed the important references if you are interested to know more about COVID-19 and school closure, as well as obesity and COVID-19 in children. And thank you very much for your attention.
Hi, Nathalie. We didn't have the chance to present you, so can you present yourself and your affiliation?
So I'm a pediatrician specialized in public health and global health policy. And I'm working at the University Hospital of Geneva. And I have the honor to be the president of the European Association for the Study of Obesity. And thank you again for inviting me to participate to this webinar.
Thank you, because you have vast experience and you are in charge on a very important issue. So we have several questions. So I will read it and let's see. So the first one is there is concern that children could be asymptomatic carriers and infect parents, grandfathers, and caregivers, especially in the communication where it's traditional. So yes, for extended families to live together, what would you say about this? Would schools closure for a longer period to be beneficial in this situation? And another very related question is, did any Geneva kid infect their grandparents? Would you recommend it no visits for older people during oncoming influenza or COVID-19 dual pandemic? So there is a fear of transfer from kids to grandfathers or to parents. What do you say?
Oh, these are interesting questions. Well, we have now the data from Switzerland, but also from many countries across Europe. And what we know now that we haven't found any transmission between children and from children to adults. So when we trace the people and the infected people, we see that the first one is usually an adult, and then the child get infected. It's usually in the same family or the people who live together. So we had many questions from the teachers or from the parents. Oh, the kids are going to school, back to school, and then they will bring the virus at home. But we didn't have any problem, and we even in the last 3 weeks, we imposed school to children. So children had to go to school, even if one parent had a chronic disease. So we just set up more hygiene, so hand washing, cleaning, having a shower when arriving at home for when the parents were really vulnerable to COVID, and maybe maintaining some distancing. And the same for grandparents, so they could visit their grandparents, but keep some distance.
So this is a really very important message, because I'm sure in other countries, as also in Israel, there is eruption in schools, and we saw also teachers that were infected. So what you are claiming is that the transmission is not from children to teachers or to the elderly, but it's vice versa, meaning that the parents are infected the children, right?
Yes, so this is why we maintain a distance between the teachers and the children at school. So the teachers had to stay away from the kids, and
Okay.
not the reverse.
And I saw in, no, it's important because, we thought the opposite. I saw in your recommendation that below 16, you didn't demand the physical, physical distancing, because they are not infected each other. The children are not infected.
We have,
or because it's too hard
in Switzerland, but also in the French data, the data from the Netherlands. We haven't found any clusters of adolescents or children. So, and same in Sweden. In Sweden, they haven't closed the school, and they didn't have clusters of sick children. So I think children seems to be protected by this infection. They have probably a good immunity, maybe slightly less ACE receptors. And we don't know everything about that. We have only now about 4 months of experience, but I think we are really reassured, and we opened the school more than 6 weeks ago in Switzerland, and we didn't get one cluster of infection. Mm-hmm. And the kids live normally at school. They really live normally.
Yeah, I think it's a very important message. The last question is that, do you have any experience with medication? Did you use medication for children?
No, nothing. We had very few cases, but we had 3 cases in Geneva. We had 3 cases in intensive care unit, as I said, and they had obesity, but we didn't use except anti-inflammatory drugs. We didn't use anything. Yeah.
Mm-hmm. So great, Nathalie.
Yeah. So thank you very much, and for this inviting me to this webinar, and I hope that we will know better in maybe a few months. Yeah.
Yeah, we all hope. Thank you very much, Nathalie.
Bye.